कोविड कोविडची शक्यता परत उद्भवल्यामुळं आपण महाराष्ट्राचे टास्क फोर्सचे चेअरमन जे होते डॉक्टर शशांक जोशी यांना इन्व्हाइट केलं होतं आणि त्यांनी न्यू अपडेट्स ऑफ द कोविड अँड कोविड मॅनेजमेंट याच्यावर त्यांनी एक लेक्चर डिलिव्हर केलं होतं. त्यानंतर आपण मागच्या महिन्यामध्ये एक पब्लिक हेल्थ डिपार्टमेंटसाठी नेहमीच कळीचा विषय असतो की पोस्टमार्टेम, सेक्शुअल असॉल्ट, सेक्शुअल व्हायलन्स आणि प्रेझेंटेशन इन द कोर्ट इन द मेडिकल लिगल मॅटर. आपण त्या विषयावर सुद्धा मागच्या महिन्यामध्ये वेबिनार घेतलं होतं आणि आता ह्या ह्या महिन्यामध्ये आपण वेबिनार घेतोय आयसीयू सेटअप अँड मॅनेजमेंट वर. आपल्याला ह्या वेबिनारसाठी डॉक्टर कपिल झिरपे, डॉक्टर सुषमा गुरो आणि डॉक्टर आनंद तिवारी ही इमिनंट पर्सनॅलिटीज आहेत. त्याच्यामध्ये आपण आज डिस्कस जे करू ते आयसीयू सेटअप अँड चॅलेंजेस इन द क्रिटिकल केअर हेल्थ सर्व्हिसेस. सेकंड टॉपिक असेल आपला अप्रोचेस टू क्रिटिकली इल पेशंट्स, हाऊ टू मॅनेज इट. And thirdly, the updates on the cardiopulmonary resuscitation, that is BLS, basic life support and advanced life support. त्याचबरोबर सध्या आपल्याकडे इन्फ्लुएन्झाच्या केसेस वाढत आहेत, एस्पेशली इन्फ्लुएन्झा टाईप ए केसेस वाढत असल्यामुळं आपण एक पार्ट त्याचा ऍड केलेला आहे. आपल्याला माहिती आहे की इन्फ्लुएन्झा टाईप ए मध्ये एच आणि एन असे दोन कंपोनंट आहेत. एचच्या 18 व्हरायटीज किंवा सबटाईप्स आणि एन म्हणजे न्यूरोग्लिडेच्या 11 व्हरायटीज किंवा सबटाईप्स आहेत. त्यातल्या कॉमनली H1 to 3 आणि N1 to 2 ह्या व्हरायटी जास्त मिळतात. सध्या कॉमनेस्ट प्रिव्हिलंट जे आहे पुणे आणि अक्रॉस द महाराष्ट्र, दुर्दैवानं मागच्या आठवड्यामध्ये डेथ सुद्धा झाली आहे. तर H1N1 आणि H3N2 ह्या दोन इन्फ्लुएन्झाच्या व्हरायटी सध्या आपल्याला प्रिव्हिलंट आहेत. तर मी इमिनंट स्पीकरना हे रिक्वेस्ट करेन की आपले 3 टॉपिक संपल्यानंतर सगळ्या पार्टिसिपंटना हे रिक्वेस्ट आहे की त्यांनी चॅट बॉक्समध्ये त्यांचे क्वेश्चन टाकावेत, विशेषतः इन्फ्लुएन्झा विषयीचे आणि जे काय तुम्हाला आयसीयू सेटअप मॅनेजमेंट ऑफ द पेशंट किंवा रिससिटेशन संबंधी असतील ते त्या दोन्ही विषयाचे प्रश्न टाकावेत. आपले इमिनंट स्पीकर जे आहेत तिन्ही स्पीकर त्याला आन्सर करतील, जेणेकरून आपल्या ज्या काही क्वेरी असतील त्या क्वेरी सॉल्व्ह होतील. मी सगळ्यांना हे रिक्वेस्ट करतो की सगळ्यांनी पूर्ण वेळ वेबिनारला बसावं. आपण ह्या वेबिनार एमएमसी ऍक्टिव्हेशन करत असल्यामुळे आपल्याला एक क्रेडिट पॉईंट सुद्धा आपल्याला मिळत आहे आणि विशेषतः गव्हर्नमेंट मेडिकल ऑफिसरसाठी ही सुवर्ण संधी असते की त्यांना बाहेरचे वेबिनार किंवा वर्कशॉप अटेंड करता येत नाहीत आणि कॅपॅसिटी बिल्डिंग किंवा कंटिन्युअस मेडिकल एज्युकेशन या प्रकारामध्ये जे काय आपल्याला क्रेडिट पॉईंट पाहिजेत ते क्रेडिट पॉईंट मिळत नाहीत. त्यामुळं हा सुवर्ण योग आहे की आपलं नॉलेज अपडेशन होतंय, कॅपॅसिटी बिल्डिंग होते आणि बरोबरच आपल्याला एमएमसीचे क्रेडिट पॉईंट सुद्धा मिळतात. लवकरच सर डायरेक्टर हेल्थ सर्व्हिसेस पुणे हे जॉईन होतील, ते आपल्याला ऍड्रेस करतील आणि अशी शक्यता आहे की आम्ही मंत्री महोदयांना सुद्धा रिक्वेस्ट केलेली आहे, आरोग्यमंत्री डॉक्टर तानाजी सावंत यांना रिक्वेस्ट केलेली आहे की आपणही येऊन ह्या इन्फ्लुएन्झाच्या सध्या ज्या काही छोटी मोठी साथ चालू आहे त्या संबंधी आम्हाला गाईड करावं. तर ह्या दोन्ही इव्हेंट पर्सनॅलिटीज लवकरच जॉईन होतील. तोपर्यंत आपण एक साधारणपणे 5 ते 7 मिनिटाची प्री टेस्ट आपण सुरू करूयात. प्री टेस्ट चॅट बॉक्स मध्ये टाकलेली आहे. तर सगळ्यांना विनंती की प्री टेस्टचे जेवढे काही क्वेश्चन्स असतील ते साधारणपणे 5 ते 7 मिनिटांमध्ये पूर्ण करावेत, जेणेकरून आपण आपलं वेबिनार पुढे सुरू करूयात. थँक्यू.
गुड आफ्टरनून सर. सर जॉईन झाले सगळेजण आणि आपण आता सुरू केली होती पहिले प्रिलिमिनरी आपलं जे प्रीटेस्ट लिंक आहे ती पाठवली होती. तर एक 5 ते 10 मिनिटाचा वेळ त्याच्यासाठी दिलाय. पण तुमच्या आता नंतर तुम्हाला जर लवकर जायचं असेल तर मे बी वी कॅन स्टार्ट विथ युअर ऍड्रेस.
यस, म्हणजे मला वाटतं आपण सुरू करू.
कारण स्वागत करते या वेबिनार मध्ये. आणि आता आपल्याला डॉक्टर नितीन आंबाडेकर सर डायरेक्टर हेल्थ सर्व्हिसेस आहेत आपल्या बरोबर. तर ते आपल्याला एक ह्या वेबिनार विषयी आजच्या थोडा ऍड्रेस करतील. सो आय रिक्वेस्ट सर.
नमस्कार सगळे, आज या वेबिनारला जॉईन झालेले आहे. अतिशय महत्वाचा वेबिनार आहे. आम्ही त्याचे जे सब्जेक्ट आहेत ते पण थोडं ट्विक केलं आहे, कारण आपल्याला स्वाईन फ्लू त्याच्यामधले जे काही 2 प्रकार सध्या चालू आहे, H1N1, H3N2, याबद्दल बरेचसे लोकांच्या मनात संभ्रम आहे आणि आपल्याला त्याच्या क्लिनिकल मॅनेजमेंट आणि क्रिटिकल केअर मॅनेजमेंट याच्याकडे लक्ष देणं आवश्यक आहे. कारण शेवटी जोपर्यंत डेथ होत नाही किंवा क्रिटिकल पेशंट होत नाही तोपर्यंत आपल्याला लोकांमध्ये पॅनिक तयार होत नाही. मात्र डेथ किंवा अशा गोष्टी व्हायला लागल्या थोडं पॅनिक तयार होतं, है ना. सो या अनुषंगाने आपण हा वेबिनार ठेवला आहे की जेणेकरून आपली क्रिटिकल मॅनेजमेंट एक्सपर्टच्या माध्यमातून अजून चांगल्या प्रकारे आपण सुरू करू शकू. मी या वेबिनारसाठी आलेल्या सगळ्या एक्सपर्टला पण धन्यवाद देतो. त्यांचं स्वागत करतो या वेबिनारसाठी की ते पण आपल्याला वेळ देतात आणि त्यांचा तज्ञ सल्ला पण आपल्याला उपलब्ध होणार आहे. मात्र सगळ्यांनी एक लक्षात घ्या की आपल्याला आता जी काही वेव आलेली आहे, 2 वेव कंबाईन सध्या चालू आहे. म्हणजे जर आपण तसा जर विचार केला आणि कोविडची जर वेव बघितली, आपण जरी त्याच्या सायन्स सिम्पटम्स हे सिव्हिरिटी नसल्यामुळे जरी आपण रिलॅक्स असलो तरी स्प्रेड हा अतिशय फास्ट होतोय. त्यामुळे त्याच्यामध्ये जे काही प्रपोर्शनेट क्रिटिकल पेशंट राहतील ते सुद्धा आपल्याकडे काही दिवसात सुरू होतील, जर ही वेव त्या पीकला जाऊन कमी झाली नाही. कारण मागच्या काळात ज्या काही 3री 4थ्या वेव्हच्या विषय आला होता त्यावेळी बऱ्यापैकी आपण इम्युनायझेशननी कव्हरेज केलं होतं. आता दुसरा म्हणजे याच्याबद्दल तज्ञ अधिक चांगल्या प्रकारे तुम्हाला सांगतील. मात्र आता यावेळेस आपण बघतोय की मागच्या वर्षभरापासून आपलं इम्युनायझेशन वॅक्सिनेशनचा स्पीड खूप कमी झालेला आहे. आपले बरेचसे जे एल्डरली आहेत ते अजूनही बूस्टर डोस पासून म्हणजे त्यांनी बूस्टर डोस घेतलेला नाही आणि किती दिवस इम्युनिटी राहते हा अजूनही मला वाटतं पूर्णपणे न सॉल्व्ह झालेला इश्यू आहे. सो त्या अनुषंगाने जर बघितलं तर जास्त लोक याच्यामध्ये इन्व्हॉल्व्ह झाले तर कदाचित क्रिटिकल पेशंट आपल्याला पुन्हा दिसायला लागू शकतील. दुसरा भाग जो H3N2 चा म्हटलाय, आताच म्हणजे याच्यामध्ये जे काही असोसिएटेड डेथ ज्यांच्यामध्ये आढळून आलेल्या आहेत त्या थोडं काही ओल्डही आहेत, यंग आहेत, प्लस नेहमी आपण जे म्हणतो त्यांना कॉम्प्लिकेशन असलेले लोक आहेत, हॅरिस लोक आहेत. ठीक आहे. सो या गोष्टीचा विचार करता म्हणजे क्रिटिकल पेशंट होतात आहे. स्वाईन फ्लू मध्ये पहिलेही क्रिटिकल व्हायचे, त्यांच्याकडे आपल्याला मात्र लक्ष देणं आणि अर्ली ट्रीटमेंटवर आणणं हा अतिशय आपला महत्वाचा त्याच्यातला पार्ट आहे. आपण क्रिटिकल पेशंटला याच्यामध्ये ट्रीटमेंट देणं, कशा प्रकारे आपण ट्रीटमेंट देऊ शकतो, डेथ होणार नाही याची काळजी घेणं हे अतिशय आपल्यासाठी महत्वाचं आहे. आणि त्याच दृष्टीने हे क्रिटिकल केअर मॅनेजमेंट म्हटल्यावर कुठल्याही प्रकारचा आजार असू शकतो तो क्रिटिकल केअर मध्ये गेल्यावर आपल्याला त्याला ट्रीटमेंट द्यावं लागतं. प्लस स्पेसिफिक लक्ष त्या इन्फेक्शनच्या रिलेटेड देऊन आजचे वेबिनार आपल्याला हे सुरू करायचं आहे आणि त्याच्यामध्ये आपण सगळ्यांनी कृपया लक्ष देऊन ऐकावं. आपल्याला बऱ्याचशा गोष्टी माहीत पण असतील तरी सुद्धा आपण अजून याच्यामध्ये आपलं नॉलेज रिफ्रेश करून घ्यावं तज्ञांमार्फत आणि आपण चांगल्या प्रकारे कुठल्याही प्रकारे डेथ होणार नाही आपल्या इन्स्टिट्यूटमध्ये हे सगळ्यांनी लक्षात घ्यायचं मला वाटतं लक्ष ठेवणं आवश्यक आहे. सो अगेन मी पुन्हा जास्त आपला वेळ घेणार नाही. मात्र मी या वेबिनारसाठी जे तज्ञ आले आहेत आपण पार्टिसिपेट झालाय सगळ्यांचं स्वागत करतो. आपण याच्यामध्ये खरोखर लक्ष द्यावं, कारण अतिशय रिलेव्हंट आणि आज आपल्याला काही दिवस तरी भेडसावणाऱ्या विषयावर हे वेबिनार आहे. मी SHRC सुद्धा अभिनंदन करतो की त्यांनी कमी वेळामध्ये, आणि तज्ञांचा पण आभार मानतो की त्यांनी कमी वेळामध्ये याच्यामध्ये स्वाईन फ्लू आणि H1N1 H3N2 च्या मॅनेजमेंट बद्दल आजचा टॉपिक इन्क्लूड केला. सो थँक्यू वन्स अगेन. आपण आता कंटिन्यू करू. डॉक्टर देशमुख आणि डॉक्टर प्लीज कंटिन्यू.
येस, थँक्यू सर, थँक्यू फॉर जॉईनिंग. सर एक रिक्वेस्ट होती की माननीय मंत्री महोदयांना रिक्वेस्ट केली आहे का सर जॉईन होत आहेत का त्या संबंधित? हॅलो सर. माननीय मंत्री महोदय जॉईन होणार आहेत सर?
नाही, ते सभेमध्ये मागण्या सुरू झाल्या, मलाही जावं लागेल. सो आय थिंक त्याच्यामध्ये ते बिझी राहतील. सो वी कॅन कंटिन्यू.
Okay, sir. Thank you, sir. Thank you very much, sir. Now we'll start our webinar with the first lecture from Dr. Kapil Jilpe, who is the head of the Neurocritical Care Rubyol Clinic, Grand Medical Foundation, Pune. He is a course coordinator for the fellowship of the Neurocritical Care, Diploma in Critical Care Medicine, and fellowship in the Critical Care Medicine at the Grand Medical College, Rubyol, Pune. He is the head of the Institute of the COVID Clinical Management Team and the policy maker of that hospital. He is an editorial board member of the Journal of the Critical Care Medicine, that is IJCCM. He is also the editorial board member of the Journal of the Cardiac Critical Care. He has 15 books under his arms, 75 plus research articles, and 60 publications, and more than 500 invited lectures at the national and international conferences. He possesses various awards and honors, such as felicitated by the Deputy High Commissioner of the British Embassy, proud recipient of the President Citation Award by the President of ISCCM in 2021. He is a proud recipient of the prestigious FICCI Healthcare Excellence Award in 2019 for the stroke code project in the patient safety category at Delhi. I request Dr. Kapil Jilpe sir to start with his presentation on the ICU setup and challenges in the critical care health services. Dr. Kapil Jilpe sir.
Yeah, good afternoon, sir.
Thank
Good afternoon to everyone. I know this topic is not a very routine topic, but I always say that this topic is a must topic. So let's see what we can discuss it today. Slides are visible, sir? Hello?
Yes, sir, it is visible.
Yeah. So today's topic is a critical care and what current challenges we all are faced, because it's a very fancy word. Generally, critical care, ICU, this is taken as a fancy word. There are high technology, so many machines, trained doctors. Is it critical care? That's what my question to the start one. So this was a hospital where I am still working since last 27 years. This was a 1959. Our founder, the late KB Grant, founded with the 6th bed. And this was in 1995 when I was working in ICU as a senior registrar. And today it's changed to the this type of the ICU. So what over a period of the last 27 years, what must have been changed, and what is the gain as a critical care specialist, whether I become a more techno savvy, or I am the one of the most advanced critical care, or I learn the humanization in ICU. That's what the topic of the discussion. So if you see, the ICUs are not only for ECG monitoring, arterial blood pressure, temperature, or hi-fi management. I always say that the ICU is where we keep the all moderate to serious ill patient or certain patients who need observation to just go through, give them the confidence. They are coming out of their family. They are in a new environment. They are under the fear of the life. They are getting a lot of pain and a lot of other complaint. And we have to give them all this relief along with the mental confidence that yes, we are there, we'll solve your problem. Don't worry. Might be next day you will be out of this environment. And that is what ICUs are not the lines, catheter or procedures or hi-fi monitors, or there is all doctors are in a seriously face moving around and trying to prove that they are the best doctor. That is not ICU. This slide always give me realization that the first first coronary care unit in India open up in a KM Hospital, Mumbai, government hospital. Why we are why we are underestimating the government and the corporation hospitals? Our every first in India comes to the government hospital and corporation hospital. Then why private hospitals are dominating? Why we are giving so much importance to the private hospital as compared to the government hospital? That is what always in my mind. And the first medical ICU in 1985 again came in the KM hospital. I think these are the proud moment. We should not say that we don't have facilities, we don't have money, government is not supporting, we don't have a ventilator. I don't think that is a criteria for rejecting or deferring the patient. Your all first are coming mainly from the government or the corporation hospital. So we all should be proud that our systems are well trained, well established. We need to revisit to them. And that's what I'm going to discuss in next half an hour. Now, ICUs, we call it critical care unit or intensive care unit. They are more or the same. It is just nomenclature that doesn't make in difference. Now, the first question I have asked in my pre-test, all are true except. So generally there are the class 1, 2, 3.4, 3. These are the 3 levels where the ICUs are divided like a primary care ICU, secondary care ICU, and tertiary care ICU. This last was the wrong option because tertiary care level ICUs that were the majority in a private hospitals, which are the trained doctors and the trained intensivists with the qualified degrees are there. So the doctors criteria was wrong. So that's why this option is not a right option. There was some typo error in your pretest. So might this question will be not counted in that. But then why these levels were made? Simple, as per the responsibility. Don't go by the anything. Just go back to your own hospital. Just see your ICU. What facilities are there in terms of the indications, capacity, nurse ratio, monitoring, unit design, integration, and the responsiveness. So on that basis, you decide whether yours is a level 1, level 2, or level 3 ICU. Why this categorization is important? Because if you know that your level ICU is level 1, don't try to retain the patient. Don't try to keep them for more than 24 hours. The purpose of the level 1 ICUs, that's what the most of the PSC or the remote centers just stabilize the physiological parameters. BP कमी झाला, BP support केला. Heart rate जास्त आहे, heart rate control मध्ये आणला. Temperature आहे, anti paracetamol दिली. Dehydration आहे, IV fluid दिले. So the job of the level 1 ICU is to just optimize the patient within that 24 hours. We are not supposed to retain the patients for more than 24 hours. So one should know what level their ICU is. Level 2 is a basic support feeling. Like you can continue till the IV fluids are going on. You may add 1 or 2 inotropic support. जर तुमच्याकडे फॅसिलिटी असेल तर तुम्ही नॉन इन्व्हेजिव्ह व्हेंटिलेशन देऊ शकता, हाय फ्लो देऊ शकता. So level 2 ICUs आणि level 3 ICUs means all advanced care ICUs. Their invasive ventilation is available. There is a dialysis facilities are available bedside. There's a surgical intervention is available if required. Source control is available. Trained doctors are there. Then labs are much more advanced. You can get the immediate within 2 hours the report, and ABG comes within 5 minutes, or ABGs are established in ICUs only. So level 3 ICU. So the most important thing, you should know where you are working. Don't compare. You can't compare with the level 3 and you can't compare with the level 1. If you are level 1, you should know that what I am supposed to have in my ICU. What I am supposed to have, I should have one doctor, either MD or MBBS, some experience in critical care, at least 6 months in critical care areas, or during the residency as a work in ICU. That is more than sufficient for level 1. I don't want the critical care train or 3 years degree, DNB. If you are giving the DNB critical care in a level 1, probably you are misusing the resources. Level 2 might be you go to the MD level or this thing, and level 3 are generally managed by the all specialist intensivists. Now, I am so happy with the COVID that, sorry to say that everybody is scared about the COVID. I'm very happy with the COVID that COVID give recognition to the intensivists. COVID give recognition to those personnel who are working in ICU. COVID give recognizes to the ICU nurses, ICU doctors, ICU ward boys, ICU mouses. Otherwise, nobody was aware of this technology. There was no respect. Nobody was accepting it is a different specialty. And during the COVID, I am so thankful to all my colleagues from all over India. They prove that they are the one of the most important part of the government agencies and the private hospitals who save the millions of the life. So that's what one should understand, what level you are working, what is your job, what is your responsibility. Nurses, like level 1, you need 1:4, no need to go for the 1:1. But in level 3, might be you go to 1:2 or 1:1 also. Monitoring. So when you are preparing the ICU at your hospital, this hospital side is 50 capacity. You are a remote place. Level 1 ICU, you have very basic requirement, like you can ask for the pulse oximetry, non-invasive BP, and if possible, have the cardiac monitoring. Level 2, you just go further with the central venous pressure monitoring and the invasive methods of the blood pressure. Level 3, you should have everything. So this is how you are going ahead with the level differentiate, and then level design, the 10 bedded, 15 bedded, 25 bedded. I will come to that. What are the problems? So please, the first point I want to insist to everyone that you first go back and just decide which level your ICU, and accordingly that demand for your personnel, demand for your resources, demand for your facilities, and manage the ICUs. And don't, if you are level 1, don't retain the patient more than 24 hours. Level 2 might be after 2 days you can refer, and level 3 you are not supposed to refer it to anywhere. Now, on this background, now we know that the intensive is a specialty. We know that ICU now recognized worldwide that these are the one of the very important department of the every hospital. And like our director also say that now this is our life. COVID will go, then S3 and 2 will come, then S3 and 5 will come, then N5 and 3 will come, and on and on and on will be the facing the pandemic, endemic, epidemic. We are at the center place. We will be in the limelight. We should be the play our role. So we should be geared up with our this thing. So that's why we should know what are the challenges. During COVID, we suddenly realized that the whole system has to be the area. We didn't have the oxygen plants. We didn't have the our own oxygen plant. People were rushing for the oxygen. People were rushing for the bed because there was no management of the bed. Because it was never, we do not have a concept of the isolation wards and ICU till COVID. And then all words were the fancy and the new. Quarantine is new, then lockdown is new, social distancing is new, isolation is new. So everything new and we were old. So the next question is I will test you the very basic knowledge. What are the location of the ICU? Everyone will say it is ground floor, and it is a wrong answer. Please, ICU should be never at the ground floor. That is, I am speaking evidence based. If you have 2-story, 3-storied or 5-storied building, ideally it should be the first floor. It may be on a 10th floor if the good lifts are available, good lift communication is available, or multiple lifts are available, like a patient different, emergency different. And it should be the close proximity with the ICU. This is what the evidence base. Unfortunately, all government ICUs, and they are on the ground floor. So we face a lot of problem with the relatives. We face a lot of problem with the privacy. There's a lot of problem with the infection control, crowd control, and all sorts of problems are there at the ground floor level. So a right answer for this question is the ground floor is not the, I mean, this answer is wrong. It should not be at ideal. So this answer is wrong. Except means this except is the right answer. Don't take it in other way. So next question, how many bedded ICU should we have? Somebody will say 10, somebody will say 15, somebody will 25. There are already proper guidelines. The moment if you go about the 12 bedded, it will be difficult to manage. So ideally, your size should be 10 to 15. Less than 6 is not viable. Not viable. Financially, resource-wise, the return to whatever your returns will not be there. So less than 6 bed, not more than 15 bed, it will be the difficult. Ideally, it should be the 5% of the total bed capacity. So if you are 50, then you go ahead with that. If you are 100 bedded, you can go ahead with that. So like that minimum. So 5 to 50, 25% is your ICU beds. Less than 6 is not viable. More than 15 are difficult. If you say the doctor-nurses ratio, for example, what evidence says, if the ICU is 50, one consultant per 7.5 bed in a tertiary level, a level 3 I am talking, not level 1 level. So for 15 bed, we need 2 consultants and the 2 registered doctors. So that like that, there are the guidelines. Let's see that will not go into detail. Look at the layout. Whoever made this ICU, one should felicitate him. Look at there is oxygen is there, suction is there, everything is there, except there is no space for doctor and the ward boys and the sisters to move around. How can they work? This is one of the worst design. That is what the layout. Now on the top, he has things so much that he has given the relatives bed. Imagine, he has a patient trolley, he has a good bed, he has a hand hygiene facility at the bedside, he has a relative bed, he has a dustbin, everything is there except there is no space for doctor and sisters to move around the bed. Bad design. Other way around, there are doctors, everything is there, but there are limited number of the beds. So on one bed, you have to. This is very routine scenario. I work in a government hospital, Solapur, for 3 years, and it was a worst situation. We never had a beds available as compared to the patients were coming, and PICUs are always flooded with the so many this thing. So look at they are managing in ICU, intubated, ventilated, all seriously kids on the one bed and the 2 patients. Worst scenario, look at there are the oxygen line, there are the suction line, there are the fans, there is a IV hanging facility, there are the beds, but there is no space for doctors, nurses, and the move around. Everything is crowded, not acceptable. These are the challenges. This can be easily managed. I know everyone of us are aware. I know everyone of must be laughing at us, but this is what the scenario in India. So how ideally it should be? Generally, ICU beds are range from 40 to 24. Generally, patients say that they are very noisy because there are so many people are working. They have different structures. So ideally, the ground floor should not be ICU location. First floor is the ideal location. Higher floor acceptable if you have multi-story building with the good lift facilities, already I explained. Your corridors, lifts and ramps should be spacious enough to move around. Look at that's what I'm saying. Where if suppose this patient had a arrest, what Dr. Anand Tiwari will do? Nothing. Even he will find he has to do the huge effort to reach this patient. If you want to shift to the level 3 ICU, how this bed will come? There is hardly space for the movement, and there will be chaos. So your corridors, lifts, everything should be spacious. So whenever you are planning ICU in your ICU, please take a part in a designing. Don't leave it with the administrator. Administrators are worse for that. They will see only the how many beds they can fit in. They never understand all these basic concepts required to run the ICU. And again, I said, I'm not talking about the hi-fi ventilators and the monitors and the this thing. So ideally, beds should be in between 5 to 25, and it should not be the less than 5% because it's financially not available. This week, the paper we have presented we have published in the Index Journal IGCCM regarding the how to plan ICU and how to design that. I hope you will go back and read this. It was very much detailed with the evidence base. Try to guide everyone that how ideally should be your ICU. So already I explained. The moment if you go about the 12 beds, they will be more noisy, more stressful, and more out of the control management. Now you can keep the ICU as per the space available and money available. They can't be dormitory like that, like open ICU. They can be single cubicles. They can be the semi type of the ICUs, and they can be isolation positive or negative room. Dormitory ICUs are a general ward. Dormitory ICUs are poor ICUs for poor people. Dormitory ICUs are in a government is a myth. Dormitory ICUs are equally acceptable and successful as compared to the single cubicle. In Ruby Hall, my ICU since last 25 years is the open ICU. There are no cubicles. There is no spacious this thing. So I never say that I will not admit the VIP patient. I will not admit all those officers. I will not admit the celebrities. I say, this is my ICU. I am available. This is my team. These are our results. Are you going to admit? Admit. If your problem, go to the hi-fi luxury ICU and whatever the services get there. So please, the reason to put this is not to say or की बाबा डॉर्मिटरी आयसीयू म्हणजे अगदीच गरीब लोकांचे आयसीयू असं काहीही नसतं. डॉर्मिटरी आयसीयू इज वन ऑफ द डिझाईन ऑफ द आयसीयू. टेक इट एज अ वन ऑफ द डिझाईन ऑफ द आयसीयू. नाउ रिगार्डिंग द ह्युमन रिसोर्सेस, आतापर्यंत आपण सगळं जागा आणि ह्याच्याबद्दल बोललो. Now look at this. I mean, this is again the government hospital picture. I am not criticizing. Please don't take it the other way around. Okay, I am criticizing the government ICU. I'm trying to find out where the things are going wrong. Look at this picture. There is a monitor. There is a non-invasive BP. There is a good monitors. There is a syringe pump. Very stylish syringe pump. Advanced non-invasive ventilator. Class of the monitor. Good beds. Everything is there. One staff. We don't know the qualification. We don't know whether she is trained or not, whether she is a student nurse, and she is managing the 2 ventilated patients. I think we need to find out whether there is adequate resources are there. Further worse situation, look at this bed must be the in lakhs. This again in lakhs, non-invasive. Monitors, very class monitor, everything is there. Good bed, Fowler's bed, Janak bed, 2 lakh cost. Everything is there except the doctors, nurses, and the ward boys. Do you think this is ICU? I don't know why government is spending so much money. Government has, or any administrator, not the government, any administrator has enough money or huge money and resources to put the things in a infrastructure, but it never bother about the human resources or the manpower. How many doctors, what is their training, how many sisters, how many qualified sisters, how many ward boys, how many maushis, lab technician, physiotherapists. Nobody talk about that. Everybody talk about their, like you must be reading in the news that so hospital received the 10 monitors, 15 ventilators. They are lying there because nobody knows how to use those ventilators. This is not the ideal ICU. And then what results in that in government hospital? They will sleep wherever they will get the space. Why we are proud? We are sharing this on WhatsApp. Look at, I slept like this yesterday. Who you are? Why? Who asked you to sleep like this? You are a human being. You need rest. After 8 hours, you should leave that place. After 8 hours, if you work with the inadequate sleep and without food, proper food, you are harming yourself as well as it is a harm to your patient, because you must not be managing with the full strength. Your capacity must be the exhausted. And what you are doing? I never understood the doctors are sharing such this thing and they are proudly laughing, sharing. Yesterday I was a 36 hours emergency. You are stupid. Who asked you to work for 36 hours? No, it is a crime. It's inhuman. Don't work for 36 hours. If the manpower is less, shut down the 1 or 2 this thing. Then you will say that we have limited resources. Go back to your authorities and say that we need so much this thing if you want the services. I am not asking you to become a rebel. मी तुम्हाला प्रोवोकेट करत नाही, मी तुम्हाला इन्स्टिगेट करत नाही, मी तुम्हाला रिॲलिटी सांगतोय. कारण हे सगळं तुम्ही शेवटी पेशंट मॅनेजमेंटसाठी करणार आहे. So regarding the this question, this answer was wrong because whatever the available resident doctor, I don't want in ICU. I want the properly trained ICU. Like suppose if I ask the doctors to the management, they will say, okay, shift the doctor from the general ward. How can general ward doctor come to the ICU and manage the ICU patient? Is he have work anytime before in the ICU? Is he have any qualified training? Is it only doctor is not criteria to work in a ward or ICU? We need to change. We are in a 2023. Atma Bharat Nirbhar. We are now self-made, self-dependent. How long we can give a reason that no. This is not our this thing. We have a limited doctor and whatever the doctor available. How long the apron घातलेला doctor असतो हा concept किती वर्ष आपण घालणार आहे? म्हणजे कुणी विचारलं तर फोटोमध्ये दाखवायला न्यूज रिपोर्टरला की तो डॉक्टर आहे ऍप्रन घातलेला. अरे हो, पण त्या ऍप्रन मधला आत डॉक्टर आहे तो अनुभवी आहे का? That's what my point. So please don't accept that. Again, go back to your unit and find out whether you are justifying your services. Then next is qualified nurses. You need to have qualified nurses. You need to have trained doctors, trained personnel. And the most important, they have to be highly motivated and readily available for the stage people. You cannot ask the general ward sister to work in ICU because she is not geared for that. And then she will create a problem for you. the ICU nurses should be smiling, smart. At least they are self-capacity. They should have plan. They should be able to handle the relatives. I think it is more important what you need to see as a human resources. And this is ideal. I am not saying this much facility should be in your ICU, but this is ideal for the level 3. But at least the resident doctors, junior doctors, nurses, these are the must part. This part should be there in ICU if at all you are starting the ICU. Social work, I suggest to have one social work because we need a lot of support from the social work. If a counselor is not possible, but at least social work, at least please, it is inhuman for the how if you go back to your ICU and just observe, just sit on a table and just observe how much time that bedside nurse sits. कंटिन्युअसली मुव्हिंग अराउंड काय ते IV घेणार, सलाईन लावणार, न्यूट्रिशन घेणार, दे देणार, नोट्स लिहिणार, परत येणार, कोणतं सिनियर येणार, मध्येच नातेवाईक त्यांना ट्रबल करणार, पण ते कंटिन्युअसली दे आर वर्किंग. कधी जाऊन त्यांना सांगितलं, सिस्टर तुम्हाला चहा कॉफी पाहिजे का, सिस्टर तुम्हाला बसायचंय का, सिस्टर डू यू वॉन्ट टू टेक सम रेस्ट? If doctors need the rest, doctors need the tea coffee break every 1 hourly. Why can't our nurses need the coffee break? Why can't they talk on the mobile? Which guidelines say that doctor and nurses should not talk on? I came to know that there is a rule that the nurses should not speak on a mobile during the hours. After 8 hours, who speaks? Even that nursing director will not stay without mobile. They just give them the 1 hour in between. Go back, relax, have a tea, coffee, see your mobile, do the chit chat, go to the movie, WhatsApp your post, see some TV clips, news. You can wait. Suppose there are 8 works, 2 can go, 2 come back, 2 can go. That is what the working environment we should create in ICUs. ICUs are not for the serious doctors and sisters. And the only thing that there has to be the gambhir chehre karun phirayche, that is not the ICU. Qualification wise, these are the standard. These are the ideal for that 3-tier or level 3 ICUs. Level 1, 2, I said MD or MBBS worked in ICUs are the more than enough for the level 1. Level 2, MD with some ICU experience are more. But these are the ideal if you are working in a tertiary care ICU. Now, this is very important question and very important answer. The answer right is the self-care. Your sister and the doctor should have planned for the self-care. This is wrong. Shall not be the priority. No, it should be priority. They should have their self-care. They should not landed with some medical issues. They should have planned. Okay, today I have the 2 patients. One of them is bad. Relatives are aggressive. Okay, how I can handle them? What is my? Can I take the help? Can I ask for the additional sister? How to face them? Okay, today I am not in a good mood, or today I have some health issue. I can exchange the duty. There has to be the self-care. You cannot ask them to continue the duty for 8 hours and leave that patient and herself. So look at both nurses. Both are good looking, smiling, well dressed. One nurse is with the ICU, one patient is with the ward. What is the difference? Difference is very important. First thing is the qualification. Ward nurses, maybe GNM or BSc. They are GNM, BSc or MSc with additional qualifications are good. Ratio 1:5 in a ward. In critical care, 1:2 or 1:1 sometimes. Essential skills, very important. Ward nurse, empathy, sympathy, flexibility, physical endurance, okay, but ICU nurse, very important. Ability to work as a team. They should not work as an individual. They should have the organization skill. They should have tenacity to face the difficult situation. They should have a plan for the self-care. This should be taught to them. That's why that class is different. That's why that performance will be different if you give them the feeling that you are different. You are not common among the rest of the crowd. You are different. Give them that. So what to give them? Give them the infection control training. Give them the pain control training. Give them counseling training. Give them the personal care of the ICU patient, bedside as well as in the classroom. Enough time should be spent on the ICU nurses to train them for all these things. Infection control, backbone of the ICUs. Pain control is the must. Counseling, you should have that smile on face. Then only half the patients will be happy if your face is smiling. How you speak with them, how you deal with them, it should not be the machine, you should be the human. Now, when we talk about a lot of resources, and a lot of this thing. Some ICUs face the exactly opposite. That is a material dissociation. Look at 1, 2, 3 brothers and 2 doctors. Okay, for the 6 patient, but hardly any instrument is there. I mean, they have lack of the invasive ventilator, they have lack of the syringe, everything. But the manpower was good. So exactly opposite. Probably this ICU team is more geared up with the human resources, but they have a funding problem. So the other way around also it can happen in ICU. So you should have the adequate equipment, adequate oxygen port, adequate your medications, and everything has to be there. So these are the ideal guidelines. Please, I refer to this paper published in IJCSM, Indian Journal of Critical Care Medicine. It's a free article. You can go through that, which gives you the according to your level of ICU, how many oxygen outlet, how many air vacuum outlet, how many electrical outlet. How many electrical outlet is also the guideline, and how many amperes has to be there. Now, last 2-3 slides. I will not take the much time. Stressors means your doctor should not be the unhappy. If the doctor is unhappy, your nurses are unhappy, then that ICU is a sad unit. It will not be the efficient unit. So what are the things affect on your staff? Workload, lack of the protocol, lack of the administrative work, working environment. So you need to have healthy. Like I am working more than 27 years in a Rubeola ICU since 1995, but daily 8 o'clock when I freshen up and try to go to the Ruby, I feel like going to my hospital. I feel like going to the ICU because there is a working environment. I would like to meet my colleagues. I would like to discuss with them, see the patient, intensive care, discussion, new challenges. So working environment, it has to be happy. Administration, protocols. If the protocols are there now, spend some time on the protocol. So it makes the sister job easy. And otherwise, every doctor has his own idea of treating. Then this poor nurse will be the problem. So what you need to do, the healthy environment, limit the maximum number of the days working consecutively, meditation, team briefing, activities, healthy eating habits. Like you have to spend a lot of time on the meditation. How many times we spend? No, we feel that we feel that we don't have a psychiatric problem. How can I do meditation? Who told you that for psychiatric reason you need the meditation? Meditation need for everyone. For me, I need the meditation. So it is not like that. I'm a director. I don't need meditation. I'm already on the top. You need more meditation. Probably you didn't understood the your stress. Team debriefing. Every day there has to be team debriefing. You just say that these are the 2 patients are troublesome, 2 patients are good, 2 patients are like that. You need to develop your concept of the ICU. In that talk, I never talk about the hi-fi ventilators and the invasive lines and the catheters and the knowledge. I am talking the very basic issues. Still we need to do. And the last is the worst problem is the relatives. There are so many problems. Visitors came at their own convenience. Sometimes they disturb the routine. Some visitors will come and they will bypass the whole system, identify themselves. Like you will spend 15 minutes in explaining the entire serious situation, and they will say, माझ्या मामांना बोलू का? अरे मग तू बोल, मी त्यांचा नातेवाईक होतो. अरे मूर्खा, 15 मिनिटं मी तुझ्याबरोबर बोलतोय, आता तू त्याच्या मामाला बोलवतोय, इतक्या वेळ काय करत होता? Then what will happen after 15 minutes when his real relatives come? You are in a bad mood. You are in an irritable mood, and then you will speak in a rough language, and the whole entire situation will become worse. So visit management has to be there. This has to be the liberal. For serious ill patient, reduce the timing. For conscious patient, increase the timing. Sometimes we want relative insight to reduce the anxiety of the patient. So you select patient, you select your visiting timing, but there has to be the control. Always start with the discussion. Who are you? तुझं नाव काय, तुझं नातं काय, तू डिसिजन मेकिंग करणार आहे का, हे प्रश्न विचारा त्यांना. अत्यंत इरिटेटिंग असतं त्यांनी सांगितल्यानंतर की मी त्यांचा कोणच लागत नाही. कम्युनिकेशन, डॉक्टर रिलेटिव्ह पाहिजे, नर्स पेशंट पाहिजे, कोऑर्डिनेटर, एव्हरीबडी शुड हॅव कम्युनिकेशन विथ इच अदर. Antibiotics. Then end of life, we should work on that. I will not talk much about that, but your patient, every patient has a dying with dignity. They have a right to die in a comfortable. Terminal cancer patient, what you are going to offer them intubation? No, convince them for the not going for the intubation. As a doctor, you need to convince them, please don't go for this thing. So their requirement is pain relief, nausea, vomiting relief, delirium relief, secretions are there. Just do the suction, keep him clean. Like this patient had a renal cell carcinoma with metastasis, and we have filled up the terminally, we have filled up the form. So this patient is like he is sleeping quietly. His blankets are also colorful. The surrounding area has adequate enough light. So when relatives see that, okay, my father is dying peacefully, that is wonderful feeling. Please don't take a date as a negativity. Date is not a negativity. Date is not the thing we should taken in a dark. This can be the very peaceful and the pleasant to the relatives. I am speaking with a lot of responsibility. I am not saying that dying with the dignity is the right of the each and every individual. Please, this take it in a positive manner. Noise level, I will not talk about that. So look at the normal conversation at 3 feet is 60 decibel. And if you even go by the noise, we are in 100 plus noise. It's like a machi badar sometimes in ICU. If possible, do it. Very difficult job. And what is the future? Now, previously there were the hospitals were big and ICUs were small. Now the hospitals are small and ICUs will become big. So even 100 bedded will have a 50 bedded ICU. I don't know what is the problem, but we are human. Don't go by the machines. Just try and concentrate on the human behavior. Like just work on the family visitation, knowing the patient person. Just ask them, Mahajan, तुमच्या पेशंट आता झोपलेला आहे, थोड्या वेळाने तुम्ही आता महाजनला बरं वाटतं. बेड नंबर 3, you just out, the patient is sleeping. This is nonsense. So just try to connect with them. Just hold the patient's hand. I have seen one of my few consultants during the COVID time sitting with the bedside and keeping their hand into the hand with the that PP kit also. But that makes a lot of difference. I was always surprised. I used to say, why you are touching? He said, sir, already we are working in a COVID, we are in a PP, we are in a glove. But sir, 2 मिनिटं त्या 70 वर्षाच्या आजीच्या शेजारी हात घेऊन बसल्यावर तिला खूप बरं वाटतं. I think that is humanization. That's what my consultant taught me. Believe me, that consultant taught me during the COVID. He said, sir, sit down and sometimes speak with the relatives. Common courtesy with the communication, your body language, your tone, everything matters. Human behavior, we should be human, patients should be human, relatives should be human, we should be human with each other. Don't cry that there are attacks when the doctors are increasing. I personally say that there are few nonsense people are there in society, but that should not affect on the rest of the society. So what are we doing? We are celebrating the birthdays. Even patient is intubated tracheostomy, patient is on dialysis, patient is on the pacemaker, patient is on the non-invasive ventilation. We regularly celebrate the birthdays and anniversaries of the all patients with the consent of the family. And families are very happy. They are sharing on their groups. They are sharing with us. And they are so happy to spend life on that day. Look at this is what the ICU is not what I showed the figure on number 1 slide. 5 ICUs. No, ICUs are this ICU. Look at my staff is so happy. Everybody are coming and taking photo. Everybody discussing. This was made by one of my sisters giving what the patient need. They need nothing. They are not bothered about the dialysis, ventilator, non-invasive ventilation, nothing. They are smiling and they are enjoying. And in Western countries now they allow the pets. Soon we should allow. Someone says that what about the infection? अरे बाबा आयसीयू मध्ये ऑलरेडी तो एवढे इन्फेक्शन असणारा तो एक डॉग तुला अजून इन्फेक्शन आणून देणार आहे. दॅट्स व्हॉट वन ऑफ द सिनियर इंटेन्सिव्ह स्टेट फ्रॉम द युरोप. सो दे आर ऑफिशियली अलाउइंग देअर पेट्स विथ and their patients are so happy with the pets in ICU bed. These are all ICU beds. This is humanization. This is the future ICUs, and this we should do that. So to summarize, we should be the less inverse and the fewer interventions with more human care. Family presence and the participation should be open up in ICU care. I know the problems at the ground level are different. You can tackle, you know your problems better. Good communication. Spend every day 2 hours with the relatives. Unfortunately, doctors are very good in the procedures and the saving lives. We are very bad in the communication. Spain, every day, Spain, we are official 2-hour counseling in our ICUs every day since last 25 years. One consultant is allotted for that. He spends or she spends the one. They should know, they should see, they should realize, they should understand. Then there will not be the attack. Patient well-being, healthcare, professional care. We should not forget that we are also humans. We need our self-care. Humanized infrastructure, I told you that the infrastructure has to be there, and the dying with dignity. So we all believe in a patient comfort. Every one of us are believing on that, but it should get that message to the end users or those patients or the relatives and then we'll be more safe and the cheerful and more result oriented. Thank you.
So thank you, Dr. Kapil Dhirpe sir, for your pathetic, sarcastic, yet eye-opener remarks for us. Really, the medical officers in public health department at rural hospital level or the sub-district hospital are very scary about the ICUs. ICU माझ्याकडे नको, दुसरीकडे द्या. म्हणजे you have just enumerated very nicely that what is ICU and what is not the ICU.
Yes, yes,
See,
that's
that
all.
we are thinking just lots of machineries, the monitors are there, every voluntary, sorry, ventilators are there, ceiling pumps are there, then it is ICU. You have just enumerated. I again thanks for your oratory also, and तुम्ही जे पोटतिडकी ना बोललात त्याबद्दल I am really thankful of you.
Yeah.
म्हणजे आमचे
sir.
सगळ्यांचे
Thank
डोळे
you, sir.
थोडक्यात उघडले की ICU साधं सुद्धा असू शकतं.
Of
आणि
course,
व्हॉट
sir.
इज ICU नसावं. शेवटचं जे कुत्र्याचं चित्र दाखवलं तुम्ही म्हणजे त्यामुळे असं काय जाणवलं आम्हाला की ICU हे इको फ्रेंडली किंवा पेशंट फ्रेंडली असावं. तिथेही जागा असावी, पॅलिएटिव्ह केअरला जागा असावी, पेशंटच्या इमोशन्सला जागा असावी. इट शुड नॉट बी अ क्लोज बॉक्स.
Yes,
So
sir.
I
Absolutely.
very much thankful of you, Dr. Dhirpe sir.
Thank you, sir.
आताच आपल्याकडे MMC चे ऑब्झर्वर डॉक्टर अरुण हळबे जॉईन झालेले आहेत. जस्ट
Okay,
कॅमेरा फोकस करताय. ही हिमसेल्फ इज अनेस्थेटिस्ट.
I know Harbe, sir. I know Harbe, sir.
Yeah.
Sir, good afternoon, sir.
He specially came to our institution. We asked him that you should join, it is a webinar, you join from your home. No, he said, I will come to here and I will have some few words with them. So he traveled right from the Kalvinagar to my institute, SHRC, and joined our webinar. Look at the enthusiasm. Sir, काही दोन शब्द बोलताय?
सर थँक्यू. छान परखड विवेचन केलं आणि ICU कसं असावं कसं नसावं सुंदर उदाहरणांचं छान मस्त सांगितलं. खूप दिवसांनी तुझं ऐकलं आणि तेव्हा तू बोलून येऊन बरेच दिवस झाले.
Thank you, sir. Thanks for the.
Thank you, sir. Sir, I request you to join till end for our
Yes, sir.
question answer session, sir.
Yes, sir. Definitely.
Okay.
Okay.
Now we'll move to our second topic. Our second speaker is Dr. Sushma Guru. She is having the current position as in charge of the neurotrauma unit at Rudyard Hospital, Grand Medical Foundation. She joined here. She is working in the critical care unit from last 22 years. She is felicitated by ATHS HRI Foundation for the exemplary work, ethics and company performance towards. Secondly, she is professional life as the occasion of the International Women's Day. She has been felicitated. Her topic today is the approach to the critically ill patient in managing the ICU setup. I request Dr. Sushma Guru ma'am to start your presentation. Madam, are you feeling okay today? Because you are not feeling well from last 2 days, I think I learned. Why is that way? आवाज येत नाहीये.
Dr. Sushma, your voice, you need to unmute yourself. We are not getting your voice. No, I will call her. I will call her.
Yeah.
सांगितलंय मी त्यांना जस्ट 2 मिनिटं ते ऍडजस्ट करतात. इन बिटवीन क्वेश्चन घ्यायचे असेल तर घेऊ शकतो सर त्यांना जर ऍडजस्ट होतो असेल.
Ma'am, you are muted, but your audio is not coming. So I will suggest please use the headphone if you are available. Headphone, earphone, then might be audio will come. Ma'am, please earphone, headphone, Bluetooth. because problem in laptop mic.
डॉक्टर तिवारी सर आहेत ना?
Anand, you are around?
Yeah, I am around. I think if there is a problem, then
You
I-
can start, Anand. Then you can, Doctor, we can
Yeah.
ask the Anand to talk. You can introduce him and he will start. In between, I
That's
will
why
see
I'm
what.
asking Dr. Tiwari there.
Yeah.
So we're jumping on the third topic. Dr. Anand Tiwari is there with us. He's having current position as a consultant neurointensivist at Ruby Hall Clinic, Grand Medical Foundation, Pune. He is practicing in critical care for last 20 years. He is a gold medalist in anesthesia, MHS Nashik in 2001. He is FMB Critical Care Medicine distinction in 2007. Fellow of Indian College of Critical Medicine, that is FICCM, in 2019, and past executive member and the academic convener of the Pune ISCCL. He is a NAMS registered IDCCM teacher, author of the ICCCM MCQ book and the book on the critical care medicine update in 2019. Author of the case behind the review book, Intensive Care Medicine for the postgraduate students in 2019 again. And in 2022 and 21 and 22, he is the author of the critical care update books. So he has a lot of publication under his arms. I request Dr. Anand Tiwari sir, who is a senior consultant intensivist in Ruby Hall, to guide us on the update of the cardiopulmonary resuscitation and BLS and ACLS.
Yes. Thank you, sir, for those nice words. Am I audible?
Yes, sir.
Yeah, and screen is visible, I suppose.
Yes, yes.
So, yeah, I'll start on the lighter note. Now, cardiopulmonary resuscitation, though it looks as a very serious topic, but let me start with a simple note. Long back in radiology, when I was a resident doctor, and there was a person who collapsed, became unresponsive, and then the radiologist, senior consultant there, he just panicked. And the first reaction, it was his relative and became unconscious, and he just started shouting, call the doctor, forgetting that he himself is a doctor. So cardiopulmonary resuscitation, I want to suggest that it is an art and science which every doctor, or once you have completed the medical degree and before going for internship, they should have knowledge of this basic life support. Unlike in Western countries, there also the emergency workers like EMT persons, paramedics, as well as in the community, they are quite aware about this basic life support guidelines. So most of the guidelines, they are coming from the Western countries. AHA is the first one which took the lead in this, American Heart Association. And every 5 years, they are simplifying this guideline so that the guidelines for the lay person can also start the basic life support so that the life can be saved and the time lag will be not be there. So I'll be discussing about the latest cardiopulmonary resuscitation guidelines, which will prepare the cognition which the medical officers can learn and then can spread among their junior staff, and everybody should be aware about that protocol. So you don't have to think too much what to do when the person become unresponsive. So the learning objective will be to understand the chain of survival. We know that the time is the essence. Basic life support algorithm doesn't require any instruments. It doesn't require any hi-fi instruments, just common sense and how you're going to resuscitate the patient. I will discuss about the high quality cardiopulmonary resuscitation. Automated external defibrillator. Most of us has visited common places like mall or restaurants or sometimes airport, where you find a device kept there and it is written public access device. That is nothing but the automated external defibrillator, which can be used in emergency. And updated ACLS for the hospital setting, I'll be discussing about the advanced cardiac life support algorithm. While we are doing this, there should not be a panic. It should be again a smooth process, and it is an intervention which we are giving for the life of the patient. Life is important. So its team dynamic is very important. And of course, after return of spontaneous circulation, after getting the patient back, we should have some post-cardiac arrest care in the ICU that I'll be covering. So let's start with this chain of survival and how we fit in here. So first is of course, the recognition. The moment the person sudden cardiac arrest is very common. It can happen anywhere, in the restaurant, in the hotel, in the hospital, in the casualty. It can happen anywhere. So early recognition of the is important. Second is the activation of the emergency response system. So nowadays we are lucky that in Maharashtra we are able to bring that number 108. So 108 is the emergency response number. If you get cardiac arrest anywhere, depending upon the location, you will get the help from there. Then high quality CPR, what you have to do is you have to start the cardiac compression. So what we are, heart is standstill. So we are going to press the heart between the sternum and the vertebral column to start the circulation to the brain. So that is a CPR. The role of AED, that is for defibrillation, early defibrillation. Delay in defibrillation will cause delay in the outcome or poor outcome. Post cardiac arrest I will be talking about. And of course, if you get a patient back to recovery, that is what our aim is. Now, this chain of survival are almost similar within hospital. Mobile number within hospital, there will be of course a different number. We have the EMS team, we have the code blue team in the hospital, but out of hospital you have to activate the 108 or whatever the health number is available. So what is important? Basic life support. So in COVID also we learned that in emergency always you should not become a victim. So first is the scene safety, where the arrest has happened. If it is on the high turnover road, the patient victim has to be moved to the safer place. So scene safety is important. We wore the personal protective equipment during COVID to not to get infected. So guidelines were different at that time. So AHA has been recommending guideline as per the every 5 years and updating it with the evidence. So recognition of cardiac arrest I talked about. These are the steps which is followed in 2020. So activation of emergency response system, starting of cardiac compression, use of AED, that is automated external defibrillator, which is very simple. It is a simple instrument which you don't have to analyze the rhythm. It itself does. Every, I think, primary health center should be equipped with AED, and then handing over to the advanced life support. So what has changed in the new guideline is like if the lay person is finding somebody unresponsive and he's not breathing or agonal respiration, that is the time you should consider as a cardiac arrest. If the person is a healthcare provider, he can check for the central pulse, like putting a hand on the carotid, but at the same time not taking more than 10 seconds. So time is very essential. So if the absent carotid or absent femoral and patient unconscious and responsive, you should start immediately with the cardiac compression. So first step is the recognition, followed by cardiac compression. So CAB is the new rule. Earlier, all this year we have been talking about ABC. So they found that during airway management, the patient when goes in sudden cardiac arrest, immediately there is no problem with saturation. It is the compression which is more important. So that's why they changed it to CAB, compression, airway, and then breathing. So what is the technique of cardiac compression? Now, there have been, you have to learn this motor skill on the mannequin. Here I can give the cognitive thing. The patient has to be on the firm surface. If somebody is giving compression on the water bed in ICU, or it's not a good, it has to be a flat surface. Then the rate of compression should be at least 100 per minute, 100 to 120 per minute. So that you give by putting your heel of hand on the midpoint of sternum, not taking care not to break the ribs. So you should not harm the patient more. You should keep on the midpoint of the sternum, and your elbows should not bend like shown in the figure here. And you use your body weight and just to fast enough to give a ratio of 30:2 with adequate chest recoil. So what you are doing is you are creating systole and diastole by this movement, and you have to push hard and fast. At the same time, you should avoid hyperventilation. So 30:2 is 30 ventilation to breathing. So when you are giving breathing, you should see adequate chest rise. So if you give too much of breathing, then it will cause gastric insufflation and further vomiting and other complications. So this is the correct technique of giving the high quality CPR. Now coming to AED. So automated external defibrillator or public access device I was talking about. normally after cardiac arrest, the most common rhythm which happens is ventricular tachycardia or ventricular fibrillation, which has a good prognosis if we shock the patient as early as possible. So AED is an attempt that is added in the basic life support program where the person don't have to identify the rhythm. So what you have to do is you have to place the put on the machine. There are paddles in the machine. You attach the paddles on the right infraclavicular region as shown in the figure here, and on the left side of the apex beat. And then you have to clear for analysis. There is an analysis button, and the voice prompt will come from the machine. It is automated, so it will give the voice prompt shock required. You clear off the patient, nobody is touching the patient, you press the shock button, and then you resume the cardiac compression. So your chances of getting the return of spontaneous circulation in such situation will be higher. Now, what is you mean by uninterrupted cardiac compression? So new guideline mentioned too much importance on this cardiac compression fraction. So here you are seeing that you are compressing the sternum. So the heart is getting compressed between the sternum and the vertebral column, and you are creating this systole diastole movement. So the moment you stop cardiac compression, your perfusion pressure is going down. It's going down, so your brain is not getting the circulation during this interruption. Once you start, again it builds up and your compression goes on. So this time has to be minimum. Interruption, and your compression fraction where you are getting the perfusion should be around 80%. So that is the new thing they have mentioned is uninterrupted cardiac compression. Now, with that in mind, people came up with that idea, why not use the machine for continuous cardiac compression, because human being can get fatigued. So they came with this Lucas trial, this Lucas device, which has got a pump here, and you put it on the chest and you set the machine, and it will keep on giving that compression at 1 to 1.5 inch. But the problem with this device was sometimes it's a machine, so it malfunction. It can get dislodged, it can break the ribs, inadvertent injury. So it is not found to be useful in human situations. So we have to cardiac compression by hand is what is the they are suggested. Now this is just to review the algorithm. So whenever you find an unresponsive team, you first verify the scene safety. This algorithm has to put in the ICUs, put in the emergency ward. So you don't have to remember, it should be reflex what you have to do next. Call the emergency response system by mobile device, get an AED, then assess the patient. Many times the patient is unresponsive, but his breathing is normal. You have to put him in lateral position and observe. If he's not breathing, but pulse is present, this can be situation where you have to give one breath every 6 seconds. So every patient you do not give cardiac compression. Healthcare provider can look for all these things. And if it is absent, no breathing, no pulse, no breathing, then you start the cardiac compression 30:2, that 30 compression we have talked about, and then get an AED. If it is shockable, go for shock. If patient starts to move or advanced life support team comes, you hand over for advanced cardiac life support. So that is what about the basic life support. So it is CAB, you have to remember. So that is one of the MCQs where compression, airway breathing, and you start with assessment of the victim, call for help, get an AED, and then simplified basic life support guideline. Now going to the advanced cardiac life support. Now, if advanced cardiac life support is concerned, you do in the hospital setting, you need to have a monitor, you need to have a defibrillator. More important, you need to have a team, because multiple intervention you will be dealing with. So it should not be chaos. It should be a proper procedure with coordination. So main foundation is BLS. Everyone should be BLS trained first. You should know the basic life support is the foundation of advanced cardiac life support. Here the oxygen is available. So you start giving the oxygen to the patient. You do the ventilation with AMBUVAC, that is ambulatory manual breathing unit. Of course, the skill will be required how to ventilate a patient, which you have to learn motor skill. Then you attach the monitor. The idea of attaching the monitor is to identify the rhythm. There are two shockable rhythms. One is ventricular fibrillation and one is pulseless ventricular tachycardia. Remember, ventricular tachycardia can be with pulse, but if it is pulseless, it's a cardiac arrest rhythm which needs to be defibrillated or shocked. Then once you identified, you use the defibrillator. Here, unlike AED, you are using manual defibrillator. So while you are charging the machine, your cardiac compression fraction, which I talked about, is continuous. Your person is continuously giving the compression. So your perfusion to the brain is maintained. Idea is not CPR, idea is CPCR, that is cardiopulmonary cerebral resuscitation. So you want an intact, neurologically intact patient back. So use of defibrillator, IV drugs. Drugs also, they have reduced the confusion in the new guidelines. They have omitted the atropine. So now the atropine, which was earlier in the guidelines, out. Vasopressin, which was early in the guidelines, out. So they are simplifying the things and they are using the evidence-based things which are useful. Non-shockable rhythm, asystole and pulseless electrical activity. So asystole is not a good, once the heart transfers into asystole, the chances of outcome are poor. So you do CPR only and pulseless electrical activity where you get the activity mechanical, but there is no pulse present. So while we are doing CPR, the advanced cardiac left support, you always think of the causes as well. What caused the cardiac arrest? How can I revert? So if the chronic renal failure patient coming with cardiac arrest, bradycardia arrest, you should be thinking of HNTs, hyperkalemia, whether hyperkalemia is the cause. So that will correct. So you think of the underlying cause. Until unless you release that, there's no point in mechanically continuing the cardiac compression. So these HNTs from the history will give idea: hypoxia, hypovolemia, acidosis, tension pneumothorax, tamponade, toxins. So you should think of these causes while the person is giving the CPR. And as I told that there are multiple interventions like giving oxygen, identifying the rhythm, using the defibrillator, giving the IV drugs. So it's a teamwork. So you should have a team dynamics. Your team should have a clear team, good dynamics for performing this task. So these are the two on the monitor you see here, a broad complex rhythm here, regular broad complex rhythm. So this is a ventricular tachycardia. And if you see the pulse, and if the pulse is absent, then it is a pulseless ventricular tachycardia. This should be shocked or defibrillated. That is, nowadays we use a defibrillator that is biphasic. So 120 to 200 joules maximum shock you give. This is ventricular fibrillation. There you don't see any organized rhythm. So it's ventricular fibrillation, no pulse. This is a shockable rhythm. These are the two commonest cardiac arrest rhythm. Now this is a algorithm. They have come with simplified algorithm in 2020. So this is a latest one which shows that once the patient is in VFVT, what you have to do is start the CPR, start the BLS, attach monitor and oxygen, identify the rhythm, give shock. So here you charge, person is giving the compression, you put the pedals again in the same place, right infraclavicular, left apical. After applying jelly, you clear the patient, victim, and the person defibrillates. And after defibrillation, again, you start the CPR. So first is a shock, followed by CPR. If the rhythm persists, again, there is a second shock. And you see the adrenaline role comes after second shock. So what we normally people do is rush for adrenaline. So in shockable rhythm, the role of adrenaline comes after second shock. So there you give shock and then you give third shock. If they're still not reversible, then you give amiodarone or lidocaine. So this is the algorithm for shockable rhythm. While you are giving this, the right side of the right side, you should think of HNTs as I talked about, hypoxia, hypovolemia, try to correct that. Assess your cycles of CPR. So the team leader is there, he's assessing whether the cardiac compression is going adequate, he's designing the next treatment plan. He has to talk the sister about epinephrine to be given 1 milligram every 3 to 5 minutes, and sister has to call back. So team dynamic has to be maintained, and you should look for return of spontaneous circulation in the form of patient starts to move or patient has a good pulse and BP, and there is abrupt increase in the end tidal CO2 if you are monitoring. That is a good sign of return of spontaneous circulation. Unlike shockable rhythm, two other rhythms which advanced cardiac support you see is the pulseless electrical activity. So there is a nice rhythm here, but there is no pulse. Patient is unresponsive. So this is pulseless electrical activity. If there is a asystole or straight line, many times be careful. Sometimes the leads may have got disconnected. Look clinically also patient is unresponsive. Don't jump on the patient if the monitor shows the flat line. So be careful. Check for the gain, confirm that asystole, and then start your ACLS protocol in this rhythm. You follow the left side here. Here there is a role of epinephrine first. So there is no role of shock. Do not defibrillate in asystole is important. So you give epinephrine or adrenaline 1 milligram every 3 to 5 minutes to the peripheral line. Give a 20 ml saline bolus, raise the hand. This is the normal thing which we do. There is no role of intracardiac. Don't think that I'll give directly in the heart. That is a wrong practice. Stop long back. So not indicated. Continue cardiac compressions. There is no role of atropine, no role of vasopressin, which has been removed from these recent guidelines. So consider advanced airway here. If somebody is skilled, put a laryngeal mask airway intubation here to prevent the hypoxia and look for the return of spontaneous circulation. Again, victim starts to move or increase in the PeCO2. These are the simplest guidelines or advanced cardiac life support. What are HMTs I was talking about? While doing at the bedside, you should think of reversible causes. So if the patient is a trauma patient, a lot of blood is lost, so hypovolemia can be caused, or hypoxia, hydrogen ion acidosis, hypothermia. So in tertiary care, we have ABG intra-arterial line in place, so probably that might help in finding these causes. Team is geared up with point of care ultrasound, that again at tertiary care, but it should not, basic rule should not be followed. So cardiac compression should not be interrupted. If he can do and find out one of the cause like tamponade or thrombosis through epigastric view or other view, then it's okay. Otherwise, it's not very mandatory in the ACLS. We should think of these reversible causes and try to correct it. Coming to team dynamics, so your patient is here. You have one team leader here, one recorder, one person who is dedicatedly compressing the heart, one airway person. These two can switch over if there is a problem with the fatigue. If the compressor get fatigued while compressing 5 cycles CPR, he should change with airway. And then one person dedicated defibrillator who is looking for safety of all while giving the shock. So it's a teamwork. So a sister might be giving the drug. So the team leader has to see that all these interventions are done in systematic, meticulous way. Then only you will succeed in the CPR outcome. Otherwise, it will be chaos and panic. So somebody is shouting, give adrenaline. Somebody is saying, I have given. Somebody said, oh, I have given twice. So that should not happen. So what should be there is a team dynamics. There should be closed loop communication. So the leader says 1 milligram epinephrine. The sister says, yes, loaded, given, and there has to be a message back. There has to be clear message between the team members. I am shocking the patient, all clear. So every team member should listen to that. Nobody gets hurt. Clear roles and responsibilities. So you have to decide, team leader has to decide if there's an anesthetist in the team, he should go to the airway because he's a good person to airway manage. Don't send the physician on the airway because he will not be, he'll be managing, but he'll not be that good as an anesthesiologist. So you have to decide the clear roles and responsibility. You have to know one's limitation. If sister cannot do the shock, so don't give her defibrillator role. The sister shock the patient. She has never shocked. So give the person who knows. So knowing one's limitation, knowledge sharing. If your leader is about to do a mistake, suppose he's saying, give amiodarone after second shock. So you also are a member, you know that it is given after third shock. You can do constructive intervention. You can say, sir, I think that this has to be given. This is probably also, this is constructive intervention if your team leader is about to make a mistake. And of course, after every CPR outcome, you should reevaluate and summarize the thing for the better outcome, for the better next time, and keep on auditing that. What happens to the last section? Now you have got a return of spontaneous circulation. So post-cardiac arrest care. So what is the post-cardiac arrest care? Again, there are guidelines for that. Once you have got return of circulation, you have to optimize airway and breathing. So oxygenation, ventilation, prevent hypotension. Look for the cause. Do the 12-lead ECG, and if it is the cause is cardiac, patient should go for coronary perfusion and advanced critical care. So this is the algorithm, simple algorithm. Keep the saturation at 90 to 98. Keep normocapnia, PSU2 of 35 to 45. Mean arterial pressure of more than 65 by fluid or inotropic agents. Obtain a 12-lead ECG. This is what you do in initial stabilization phase of post-cardiac arrest. Once that is done, and if you suspect cardiac intervention, so STEMI is there, you have to go for the cardiac intervention. Look for the patient whether he is following command. So if he is following command, you are successful, you do the critical care management. But if the patient is not obeying, then you have to do something to preserve the brain or prevent the cerebral metabolic rate of oxygen consumption, other things. For that, you use the TTM, that is target temperature management, where we keep 32 to 36 degrees centigrade of temperature for 24 hours. If patient is comatose, you can go for obtaining CT scan, EEG, and depending upon the neurologist opinion, and then you have to prognosticate the patient. So prognostication will be, the timing of prognostication should be after 72 hours when all the sedative and other effects are gone. It should be mostly clinical. If you have facility at imaging, EEG, lactate or biomarkers, which are usually not available in our setup. So timing is important. Head CT within 2 hours will show you gray and white matter differentiation and prognosticate. MRI will tell you after 24 hours about the hypoxic injury, how whether to proceed or not. And myoclonus is not a good sign here. Clinical pupillary light reflex is the most important after 72 hours. If it is present and corneal reflex present, patient is moving, that is a good sign. So these clinical findings with poor neurological sign is clinical pupillary light reflex absent is not a good sign. Dysglycemia present, not a good sign. But remember that patient temperature should be normal. Patient should not be in the effect of sedation while you're prognosticating. So don't hurry in prognosticating this patient. So again, the same, it shows the timing and the MRI and N2 somatosensitive depends on the availability. So best is the clinical. So multiple modality testing, but the best is the test is to perform clinical as well as the radiological as well as clinical. Now, last question, ethical consideration. When should I stop resuscitation? When should I not do the BLS? So what is your local protocol say about that? In COVID, we have different rules where you have to address the mass, you have to do the good for the most, and you have to sometimes change the protocol. So this is local protocol and patient having a valid, as Dr. Jitpe sir also mentioned about dying with dignity. So that is important, whether the valid DNR is available, when to stop. So whether I give 10 minutes, 20 minutes, 30 minutes should not be waste of resource. It should be benefiting the patient also. So if my initial rhythm is asystole, if the patient is delayed, if the age is more than 87, 60, comorbidities multiple with the advanced CA and metastasis, there is no flow time and CPR duration is much, it should be individualized decision. So it has to be decision based on this. Are there any guidelines? There are guidelines which we can follow, like if there is no return of spontaneous circulation after, or no AD shock was delivered before transport, or there is delay in the spontaneous circulation, but no bystander CPR. And as I mentioned earlier about the age and comorbidities, then you can ethically, with good communication, decide about dying with dignity and termination of CPR. So that's what I have to communicate. These are the guidelines I have taken from American Heart Association. I am the ACLS instructor, so I prefer that everyone should go to the motor skill before applying bedside, and also keep updating the thing for better good of the patient. Thank you very much.
सर थँक्यू डॉक्टर तिवारी सर.
Thank you.
तुमचा बायोडेटा वाचताना म्हणजे लॉट्स ऑफ गोल्ड मेडल अँड डिस्टिंक्शन म्हणल्यानंतर आता आमच्या डोक्यावर जातं काय असं वाटलं होतं. पण व्हेरी नाईस प्रेझेंटेशन मेड बाय यू, स्पेसिफिकली अबाउट द adult chain of survival. पहिली जी स्लाइड होती adult chain of survival, I like it very much की how flow it goes on.
Yes.
And secondly, the automated emergency delay defibrillators concept. And third is the algorithm of ALS and BLS. You have nicely depicted and explained to us. Sir, I would like to request about to give some information about the AED.
Yes, sir.
Automated emergency defibrillator.
Yes, sir.
त्याची कॉस्ट किती आहे, मशीन कसं आहे?
Yes, sir.
आमच्याकडे हा प्रकार नाही आहे जवळपास.
Sir, actually, most of the time we are not aware. When we move to the airport, sometimes you must have gone Pune airport, any international airports or Indian airport, there is a box near there are two boxes kept and it is written AED there. But people, most of them are not aware that it is a automated external defibrillator machine, which is actually, sir, it is a simple machine where there are paddles inside. It may differ from company to company. It has to be thus attached on the, you attach it on the right infraclavicular and the left apical region. And there you just have to put the rhythm analysis button. It's a very simple, there is an inline like mobile instruction. You have a new mobile and you quickly learn how to do it. So it's even simpler than that. Only one button is there, two buttons are there, one is to analyze and one is to shock. So it machine analyzes and tells that it is a shockable rhythm. So if immediately it is put and patient is shocked, the outcome is better. Sir. So even many malls and many public places, they should start keeping this automated external defibrillator machine.
सर साधारणपणे कॉस्ट किती असेल या मशीनची?
Cost varies from maybe from 50,000 onwards. I think 25 to 50,000 onwards it will be. But it is a very useful thing. In fact, in AHA, they are also studying about the drones carrying this machine to the place of victim. So if the machine is not available nearby and the victim is in some hotel where it is not available, by drone the machine will go there and then they will do the earliest shock. These kind of things are happening. So at least we should, in hospital which are not geared up with analysis and not trained staff, at least AD can be kept.
Sir, I request you, if you have any video or photograph of such machine,
Yes.
can you show it to us maybe at the end of the day or at the time of question and answer session?
Yes, sir.
If you can procure the photo or videograph of this machine, as
We
well as
have
the
like-
ALS, sorry,
Yeah.
BLS and ACLS functioning, any video, small video if you have, you can
Yes.
show up at the end of the our discussion, end of the our topic presentation and before the question answer, sir.
I'll try, sir. I'll try.
Yeah. Sir, Dr. Halbe, our medical council observer and our famous anesthetist from Pune, want to speak something about.
Yes, sir. Yes. Good evening, sir.
Good evening, Anand.
Yes,
Well explained.
sir. Thank you.
PowerPoints मस्त होते, टेबल छान होती.
Yes,
They are very meticulous.
thank you, sir. Thank you.
आणि ethical consideration छान सांगितलंस. मला खूप
Yes.
आवडलं.
Yes, thank you, sir.
आता इंडियन मेडिकल असोसिएशन CPR चं पॉप्युलेशन, रिक्षा ड्रायव्हर्स, बस ड्रायव्हर्स, आम्ही स्टाफला असं सगळीकडे आम्ही करतोय.
Yes, sir.
JDN मध्ये जे अंडर ग्रॅज्युएट आणि पोस्ट ग्रॅज्युएट डॉक्टर्स पर्यंत सुद्धा या वर्षी करण्यात येईल.
Definitely, sir. Definitely.
Every citizen must know about this CPR as in
Rightly said, sir. Rightly said, sir. Yes, sir.
under the help of the funding help, Dr. Srikant Kerkar,
Yes, sir.
the ophthalmologist. His relative was saved because of CPR
Yes, sir.
medically given at airport, USA.
Yes, sir.
So
Many,
it's
many
not
such
been
stories
done
are there, sir. Yes, sir.
Thank you.
Right, sir. Thank you, sir.
Sir, on this outside of this about the BLS and ACLS, government of Maharashtra also taken the initiative, mainly for the all medical officers who are attending this webinar. The government of Maharashtra is planning about giving training to nearly 3 crore people in the Maharashtra.
Yes.
Starting with the our RBSK team and the students of 8 to 12 standards or between the 12 to 16 age group.
Excellent, sir.
12 to 18 age group. Through our RBSK team, that is Rashtriya Bal Suraksha Karyakram, the doctors are coming to each and every nook and corner of the schools, in each and every villages. Through that team, government is proposing to give the at least BLS training to
Yes, sir.
each and everybody.
Yes, sir.
This is very
Excellent
ambitious
initiative, sir.
project we are having.
Excellent. Actually, I think it is necessary at the school level itself. Very, very well taken, sir. Excellent, excellent initiative.
Okay, thank you, sir.
Right.
Thank you very much. So, sir, be with us.
Yes,
Don't
yes.
go
I'll be there.
Because we are having question answer later.
Yeah, I'll be there.
Yeah. Now, I think Dr. Guru Madam are ready.
Yes, sir, you have already
Very
introduced.
nice.
So let's
Very
go.
nice to hear your voice again. Yeah. So directly you can start that. I have already
Yes,
introduced you.
Yes,
So
yes.
you can start your topic.
Okay, thank you.
Yeah.
Thank you. After having a nice talk of about the ICU settings and saving a patient from cardiac arrest, now let's go to approach the patient who is critically ill patient. There is a slight difference between the patient who is critically ill. We need to pick up the or identify some symptoms which will tell us that patient is having deteriorating signs. So my objectives will be, and will the correct sequence we have to run, learn, then importance to have the systematic approach to assessment and care with the rationale for each step, then will be able to demonstrate the safe and effective assessment and care for the critical ill patients. Now, what are these critically ill patients? Actually, they are failure. If we are failure to detect this disordered physiology, then they will land or they will go have to be taken care in critical care or intensive care unit, and they will land with multi-organ failure and unnecessary deaths. So it is necessary that all healthcare workers should have or should learn the comprehensive approach for assessment of an early recognition of potentially deteriorating patients. Now, the patient admitted from wards to ICU, when they do our come, they have higher mortality or higher percentage of mortality. Why they land up? Because they are not being picked up. And the sequential or protocolized approach is always been missed. And nearly 80% of the hospital inpatients who experience this arrest or cardiorespiratory arrest are from the deterioration of these patients. Now, in case of arrest, we have learned that chest compression stands high. So we have to learn to recognize this before making C come first. We have to take care of A, B, C first and learn to recognize these critically ill patients. So the top 5 signs, this was in one of the MCQs, that early signs and in late signs. So early signs मध्ये काय? The partial airway obstruction. त्यांचं circulation poor असेल, so periphery might cold. The pH less than 7.3 but greater than 7.2. आणि ABG मध्ये जर सोय असेल तर base deficit -5 to 8. Now, if the patient has undergone surgery, you need to look out the amount of drain. Drain quantity जर expected च्या पेक्षा जास्त येत असेल तर definitely this is an early sign that there is something going wrong in the patient which we need to be tackled. Late sign, these are the very late sign. So pH is less than 7.2, then patient is unresponsive to voice, base deficit is less than -8, and urine output is less than 224 hours. Means we have picked up the patient very late, or sometimes patient is anuric, he is not passing urine. So these are the early warning scoring system, that is chain of response, which that is called a modified early warning scoring system, which needs to be picked up. मग त्याच्यामध्ये systolic blood pressure, and we have given scoring system from 0, 1, 2, 3 for increasing and 0, 1, 2, 3 for decreasing. So systolic blood pressure, if it is increasing, so it is, you have to have 15% of the baseline, then 30% of the baseline and 45% of the baseline. So if the blood, we need to pick up from the blood pressure, from the heart rate also. So if heart rate is dropping down, yes, then it is also worsening, or either it is increasing, it is again worsening. Respiratory rate कडे पण लक्ष द्यायला लागेल, कमी आणि जास्त दोन्ही साइडला. So we have given scoring system accordingly, and temperature also. If temperature is maintained, it's normal, but at the same time you need to see that whether it is reducing, hypo होतोय का hyper होतोय. आणि AVPU is nothing but alert, voice, pain and unresponsive. या आपल्या ह्याला कशाला patient response देतोय. If patient is alert, he is normal. If he's responding only to voice, or is it responding to pain, or he's totally unresponsive. So score more than 5 is associated with increased mortality. So early warning signs आपण pick up करायला शिकलं पाहिजे. So why there is difference in approaches from the traditional medical approach आणि approach to critically ill patient. Routinely आपण काय करतो, हिस्ट्री घेतो, एक्झामिनेशन घेतो, मग त्याला आपण डिफरन्शियल डायग्नोसिस रीच करतो, and then accordingly we send investigations and we start diagnosing and start the treatment. But for deteriorating patient, what we have to take care is whether he is able to maintain his airway, whether his breathing is adequate, chest rise आहे का, circulation चांगला आहे का, आणि alertness, that we have seen alertness voice ला आहे, pain ला आहे का, unresponsive आहे, and we have to expose whether there is neurological deficit आहे का, or we have to examine the patient. So approach is totally different. Your priority is the parameters which are physiological parameters which are deteriorating need to be tackled first. So this is ABCDE approach, where we are going to step by step go from airway, breathing, circulation, and disability and exposure, or examine the patient completely. So the safe approach, why it is a safe approach? First is primarily we have a systematic approach so that we will not miss anything. And this is first is primary survey using ABCD. And then when we go to the traditional approach, it becomes the secondary survey. What are the rapid interventions when we go to ABCD? First includes the maximum oxygen should be given, IV access gets a pratham, fluid challenges chalu करायचे, and any specific treatment for that patient. Like if the patient has undergone some surgery, do we need to support that, or do we need to find out the drain? Then this survey should not take more than 5 minutes, and it can be repeated oftenly. If these parameters along with the physiological parameters are deteriorated, we think that then patient needs to be taken care of immediately. First thing, second thing, and need to be shifted to critical care. So, and when we know that ABCD, so it is a teamwork. So we allot a specific job to a particular doctor if we have a team. If not, then we alone have to do the survey. So first survey will allow us to decide to continue for secondary survey or ask for immediate senior review, because if patient is rapidly deteriorating, we need help, or we should call for help. So and secondary survey, as I said, once the patient is stabilized, we have corrected the oxygen, we have corrected the his hemodynamic parameters, his neurological parameters, then we go for the secondary survey. Let's see a case. A 66-year-old gentleman admitted to ED. He was unwell since 3 days, vomiting all food and fluids. So we know he's vomiting. So naturally dehydration will be there. Not passing urine. So look at, the patient has approached us late and also complains of breathlessness. So anterior chest pain, which he describes as a sharp stabbing and worse on inspiration and cough. So details that the physiological parameters, that temperature is 35, definitely it is less. Heart rate is 94, blood pressure 83/52, respiratory rate is 54, and oxygen saturation is 96. So saturation is maintained, but respiratory rate is increased and blood pressure is. So if you follow the MUSE or the modified warning sign scale, it is 3. So patient was talks with short sentences, but due to increase in respiratory rate. And there is in the respiration, there is this airway. In breathing, what we are seeing, whether there is chest rise. So chest rise chadi start from trachea. So trachea is centrally placed, chest is clear, no cyanosis, saturation was 94. So we gave 2 liters of oxygen via nasal oxygen. Then heart rate was 94 regular. Periphery is cold dead. Blood pressure was 83 systolic. And we know that patient had no urine output since admissions. So alertness, AVPU scale was, he was alert. So GCS was 15/15. And the blood monitoring arrest system was also normal. Then when we exposing the patient, we have seen that there is a ileal conduit and small amount of purulent urine in a bag, approximately 50 ml. Patient is having no fever, abdomen is soft and non-tender. So A, B, C, D, we have seen and completely exposed the patient. Now plan is, I'll give oxygen, 2 wide bore intracat लावणार, aggressive IV fluids देणार. At the same time, I have to maintain the strict fluid balance. Hourly urine output monitoring करायला लागेल, कारण 24 hours पासून urine output नाहीये. And we need to have a nephro reference definitely. Here we have VIP approach म्हणून पण suggest केलेला आहे, that is ventilation, infusion and perfusion. So it is nothing but ventilation again. ABC मध्ये जसं बघतो तसं इथं ऑक्सिजन ऍडमिनिस्ट्रेशन करायचं. Ventilation, take care of airway. Infuse means we have to give adequate IV fluids. Blood pressure is low. Here we have to rush the fluids. We have 2 intracals. Then if blood pressure is not improving, definitely we need to add vasoactive agents. Now the airway causes काय काय असू शकतात ज्याच्यामुळे पेशंट डिट्युरेट होऊ शकतो इज लो GCS, न्यूरोलॉजिकल काय असेल, स्ट्रोक असेल, नंतर बॉडी फ्लुइड कलेक्शन असेल, त्याच्यानंतर फॉरेन बॉडी आहे का, वेदर देर इज अ टूथ dislodgement which has occurred, or patient has some whooping cough, or inflammation has occurred and patient is exposed to burns, so inflammation of the airway has occurred, and or there is any trauma. So airway causes for compromise are, we have few I have been told. Then airway assessment साठी if patient is unresponsive, definitely आपल्याला advanced airway ला जायला लागेल. पेशंट मध्ये गर्गलिंग साऊंड्स आहेत का, accessory muscles यूज करत आहे का, ब्रीदिंग पॅटर्न कुठला आहे. So how we tackle the airways, head till chin lip. This we have seen in AC, just ACLS BLS course. Okay. So jaw thrust द्यायला लागेल, and if not, this is not possible, then we have to do clear the throat or clear the secretion from the throat which by using suction, and if not, then we can use the oral airway or nasal airway. Here we have to remember that if traumaचा patient असेल तर definitely you cannot do head tilt, कारण प्रत्येक ट्रॉमाच्या पेशंटला we have to anticipate that there is a cervical spine injury and spine immobilization stands high. Advanced airway मध्ये काय, you have to always get for help, and you have to have LMA in your emergency trolley, and you have to have go to for intubation also. But if your airway you are not going to, or you are not able to establish, definitely you need to go ahead with the cricothyroidotomy. So this is one of the where cricothyroidotomy, it is between the cricoid and thyroid, there is a membrane which is easily reachable, accessible, and since it is in just in the front of neck. Once the airway is open, you also give 15 liters of oxygen continuously till you rule out other causes, till you go to B, C, and D and E. So here you need to give oxygen from non-rebreathing valve. For COPD patient, definitely आपल्याला एवढा oxygen देणं योग्य नाहीये. But till then you rule out other causes, you need to give the oxygen and look for the saturation. Now breathing causes. Now we have dealt with a part of it, that is airway. Now we need to look at the breathing causes. So breathing causes or breathing can be hampered by various patients. GCS low झाला आहे, respiratory depression झाला आहे because he has had some toxins or tablets, overdose of tablets also. Muscle neuroचा patient आहे, muscle weakness. Then patient has been exhausted because he's been breathing or with a higher rate since long. Patient is asthmatic, COPD चा patient आहे, काही trigger factor आहेत, pneumonia असू शकतो, so sepsis and cardiac event which can lead to pulmonary edema, किंवा पेशंट बेडरिडन आहे, ऑपरेटेड पेशंट आहे, पेशंट ऑपरेशन झाल्या कारणाने काय होतंय, ही इज बेडरिडन, so there is not moving his legs, so he has high chances of developing DVT and which ultimately can lead to pulmonary embolism. And if not, pneumonia is not picked up in early stage, then patient present with ARDS. आणि आधीच आता आपण रिव्हर्सिबल T's and H's बघितले, त्याच्यामध्ये pneumothorax, hemothorax आणि ट्रॉमाचा पेशंट असेल तर डेफिनेटली यू हॅव टू थिंक ऑफ फ्लेअर चेस्ट अँड ओपन pneumothorax. सो ब्रीदिंग असेसमेंट साठी आपण काय करतो, यू जस्ट लुक, लिसन अँड फील. सो यू लुक फॉर द रेस्पिरेटरी रेट, वेदर ब्रीदिंग इज सिमेट्रिक, सॅच्युरेशन ॲडिक्वेट आहे का, कलर कसा आहे पेशंटचा, वेदर इज पिंक or there is cyanosis occurring. Listen whether patient can talk full sentences, whether there is wheezing, whether adequate sentences बोलू शकतो का, you have to auscultate, and whether the chest is silent. Then feel for trachea is deviated or percussion करून, and whether the expansion by keeping your chest hands on, whether the expansion is adequate. Now if you have to intervene, you have ambu bag. ambu bag ni आपल्या this is a universal mask and ambu bag असते. You have to give respiratory rate. If you have to use ambu bag and give the respiration with this ambu bag if your respiratory rate is less than 10. You have to stand at the head end of the patient. So at this you can give the respirator and you have to watch for the chest rise also. So look here, he is observing for the chest rise. Then circulation, when we have completed A, B and C. Now we when go to the circulation, we have to look for inadequate perfusion. ते कसं बघणार तर कोल्ड पेरिफरीज आहे, ब्लड प्रेशर इज ऑन लोअर साइड. सो कॉजेस काय असणार, आयदर व्हॉल्यूम लेस असणार, or your heart is not pumping properly, or there is vasodilation. So volume is less, heart is at fault, or there is volume distribution is more, and again because of that volume will not suffice for that. It can be anything, sepsis, anaphylaxis किंवा neurogenic आहे. So you have to look for the color. Examine the peripheries, pulse, what is the volume, what is the blood pressure, what is the capillary refill time. किती वेळा आपण दाबल्यानंतर नखाच्या तिथे तो पिंक कधी होतो, how many seconds it is occur. If it is definitely more than 7 to 8 seconds, it is worrisome. Urine output is another thing which will tell us about the perfusion. So circulation, how to intervene, based simple step set. You just position supine द्यायची with legs up. So this can be done easily by giving pillows, or head end ला blocks लावू शकतो आपण. Or if the female is pregnant, you have to give a left lateral position. Then 2 wide bore intracats, already we have found out. Then you have to give start the IV fluids faster, maybe with a pressure bag, blood products if the blood loss is more, and you have to look for the ECG whether there is cardiac cause to rule out, and any other specific treatment. म्हणजे anaphylaxis असेल तर definitely we have to think of giving some adrenaline. What is the cause of the drug? Then disability causes काय असणार? Yes, disability is patient is not neurologically in a proper sense. So inadequate brain perfusion आहे. Sedatives extra घेतले आहे का? So he has taken some pills. Blood sugar is not good. Adequate electrolyte imbalance आहे का? Then toxins, poisons, which you have said. Stroke आहे का? And increase in ICP because underlying disease है patient ला. There is a bleed. So disability is how we assess it. AVPU score or GCS normally जे म्हणतो आपण. So how is the patient alert? Response to voice, response to pain, or patient is unresponsive. Pupillary size बघायचा आहे. What is his posture when we give a stimulus? And then you have to look for the whether patient has pain. That's why he's not responding, or he has taken that position. In this case, we have to, as we have said, we have to optimize airway, breathing, and circulation. Treat the underlying cause, whether patient has taken any toxins. Naloxone द्यायचं असेल, opioids खूप घेतलेले असतील, कॅन्सरचा पेशंट आहे, पेन आहे, he has taken too many opioids, so he has become more drowsy. We need to rule out that. And if the blood sugars are very low, definitely we have to give dextrose or control the seizures. We have to take help of